All right, any questions from anything we covered last time? So since I'm not on a tight time constraint because you got till 1 for Taco Tuesday, I have a brief tangent to start off with. So starting off right on topic. So I was on call the other night. You know, when I'm on call for the Poison Center, I'm at home, call me up at 2 o'clock, 3 o'clock in the morning. It could be anything, right? So it's very much, you know, dealer's choice as far as what people decided to do to themselves that night. But I had a person, you know, sometimes we get foreign body ingestions. And so I had a person that actually ate an entire roll of aluminum foil. Yeah. Do you know what it caused them to do? What they manifested? It made them sheet metal. Okay. On a more serious note, though, I was on call the other night, and so I had a patient, and because this is something I probably won't get a chance to like really talk to you guys about, I figured it's a good option or a good opportunity to pepper it in here. So I had a patient, early 20s-year-old female. So this is the doc calling me from the ER. Early 20s-year-old female trying to self-harm. She ended up ingesting a lot of household cleaning products, including things like bleach, including things like Drano. She had one episode of emesis at home. She noticed there's some blood in it, and now she's here in the ER. She's brought in by EMS, so she's Baker acted, and otherwise seems to be asymptomatic. The doc's like, what do I do now? So does anyone know what the big concern is with drinking household cleaning substances? Right, so we're about the caustic nature of those products there, right? So what do you think that could do to the GI tract? Cause burns? What else? Inflammation, for sure. What else? Perforation, right? That's really the big concern, right? Because again, if they perf through the GI tract, there's all kinds of bugs that are going to be getting in there. There's all kinds of bleeding that's going on. It could be really bad, right? So the question is like, what specifically did she drink, right? And so she's like, well, she drank bleach and Drano. When you see Drano, like, what is Drano? Anyone know? So a lot of you guys don't actually know. Yeah. Yes, sir. Right, so that'll be an important point here as well. So actually, sodium hydroxide is the biggest component thereof. And sodium hydroxide is a strong acid or base. It's actually a base, right? Actually, drain cleaning substances tend to be basic solutions. Things like bleach tend to be a little bit more on the acidic side, or probably closer to neutral, maybe a little bit more basic. It really depends on the situation, but it depends on the product you're dealing with as well. Because a lot of people will say Clorox, and you're like, well, Clorox what, right? So what is in it specifically? And they Drano, what is in it specifically? So again, whenever you have someone who's coming in with these kind of ingestions, you always want to have them bring in the product itself, right? Or at least take a picture, because everyone's got a camera in their pocket, right? Take a picture of the product, they can bring it in, at least have that documented there, so you know what they got into specifically, right? So if you're thinking about, you know, drinking acids versus drinking bases, which one do you think would be worse? Why do you think bases? They're both corrosive, technically. So there's an interesting thing here that the acids tend to burn themselves out pretty quickly. They cause what we call a coagulative necrosis. They'll form an eschar, and basically it'll kind of burn itself out to where the actual tissue penetration is somewhat limited. Versus a strong base, we call that a liquefactive necrosis, and that'll just continue to burn on and burn through all those nice, you know, lipid membranes, all that fat. It'll saponify it, right? You ever seen Fight Club where he pours the lye on the guy's hand, right? I guess it's on his own hand. Spoiler for Fight Club. But it's a very severe burn there, right? And so this is one of those things where the bases tend to be worse from that standpoint. So right off the top of my head, I'm thinking, okay, well, this could be really bad because Drano itself is a caustic alkaline. It can cause really bad, you know, corrosive sort of effects there. It causes that liquefactive necrosis. And also, what has the patient already told us? Kind of indicating that she's kind of in a bad spot. The vomiting with blood, right? So that's already telling me that, hey, there's some tissue injury going on here, right? So the next question is, well, what do you do for that patient? What do you think you would do for them? I mean, give them like something to neutralize the substance? So charcoal would be a good thought. Charcoal is used to bind up a lot of substance. We'll talk about that later on in this class when we get to the tox stuff. You're going to find that for liquids, typically charcoal is not great for that, and it wouldn't necessarily do a whole lot. Now, the question is, you know, did she ingest other stuff? Possibly, and that could definitely help out with that. But the big thing you want to know about with these caustic ingestions, she's already showing there's injury there. You want to keep her what? NPO. You do not want to do anything to try to further irritate that tissue there. Okay. So first thing off, you want to make her NPO. What next? What do you think kind of referrals you want to make? And called GI, because she's probably going to need endoscopy, right? So she's going to need a scope to actually go down there and actually see what the actual extent of the tissue injury is. to see what they need to do next. And a lot of times these cases will get referred out to them, and they may need to either resect part of the GI tract. I've had cases where the esophagus has to be partially removed. Very severe cases where patients are going to be on TPN the rest of their life because so much of their GI tract has been decimated by these caustic substances. So those are the big things to think about, right? What labs would you want to order on a patient like that? You could, yeah. So you get like an ABG. It could tell you like kind of if they're more basic. And again, that's one of the things the doc had asked me. Was like, hey, what kind of labs should I get? Do I need to check on that? Typically, you're going to find the body has a really good ability to kind of buffer itself, and from that standpoint, you probably didn't get enough to really cause any big issues. You could check it, but not at the top of my list there. But young female, what am I going to check? Intentional harm, pregnancy. Always want to check a pregnancy, right? And then what else do I always want? What kind of drug level would I always want to check for? And we'll learn about this in the toxin. You always want to check a Tylenol level, right? Because again, she says she's drinking all this stuff, but could she have also maybe taken a bunch of medications on top of it? Absolutely, right? I don't know, because how can I tell when one of these patients who are trying to harm themselves are telling the truth? Or how can I tell when they're lying? Their lips are moving, basically, right? So again, you always want to take them with somewhat of a grain of salt from that standpoint, right? So again, we check a Tylenol, we check a urine pregnancy, and we get a GI referral, right? And keep our NPO for the time being. They can scope the patient emergently, figure out kind of the extent of the damage, and figure out what to do from there. The big problem is with those patients is that tissue obviously is at risk for things like perforation, but over time, when it starts to heal, that tissue, it doesn't just go back to nice, normal, like esophageal tissue. It tends to cause more scar tissue, right? So you can see strictures there, which can oftentimes impede things like food passing and whatnot. And that often will end up patients on things like TPN for life, potentially. Okay. Anyway, so just a little case. Again, sorry that was not an elaborate setup for a joke, but it was a pretty basic case. Anyway. Any questions on that? Yeah, so be very careful with acids and bases. Bases always tend to burn worse, and those are the ones you need to be kind of keep in the back of your mind. Here, sodium hydroxide, something like that, it's pretty serious business. Okay. Anyway. All right, moving forward, let's continue on with Peds. We were talking about neonatal issues, right? We talked about neonatal sepsis, and how we're going to be managing those patients. Apnea of prematurity is something that occurs here pretty commonly as well in these kids that are born a little too early. Sometimes you can try to help them out when by stimulating them, try to help them breathe, but sometimes we'll actually have some medications that can help out with this as well. Big issues here though is that they probably are having some amount of prematurity is kind of keeping them from having a regular respiratory rate, or they're not really responding to levels of CO2 appropriately. They tend to be a little bit less responsive to that CO2. And if you remember, I probably told you that case or that game that some of those residents will play called DSAT. Did I tell you about that story? Probably not, right? So what is your brain much more responsive to? Is it hypoxia, or is it hypercarbia or hypercapnia, I guess, that you're responding to? It's a hypercapnia, right? So your brain is much more responsive to that. So again, that buildup of CO2 is going to stimulate your breathe before a drop in O2 actually is. And so these patients, they don't have that same sensitivity. And so they can build up CO2 levels that can lead to apnea. And so because of that, we need to give them something to try to kind of stimulate that. Anyway, again, it could be issues of obstruction. Obviously, you need to deal with that, from an actual physical impingement sort of standpoint. But in some cases, you may find it could be a mixture of both, like kind of central effects, maybe again something with the brainstem not functioning appropriately versus an obstructive, and they can happen concurrently. And again, lots of secondary causes here, lots of reasons. It could be hypoxia, it could have sepsis, could have things like temperature instability. We mentioned when they're born early, they tend to have a harder time kind of maintaining temperature as well. That can also lead to apnea. All kinds of things can do this. And so some things we'll do to try to prevent it is, one, you can do things like tactile stimulations. You can kind of stimulate the bottom of their feet. That'll oftentimes kind of trick them into breathing. Things like that. If you have twins, usually co-batting them helps to kind of stimulate them as well. And then again, I'm going to focus on the pharmacologic management. Anyone know what I mentioned before as the drug of choice for this? Caffeine, right? So it's a very good lead-in. We were talking about caffeine right before class. And so basically, anyone know why this stimulates breathing? It's kind of a direct effect on the brainstem, but typically caffeine is working as a adenosine antagonist. Okay, so we talked about adenosine before. Where did we mention adenosine? Yeah, for SVT, right? We talked about it as an antiarrhythmic, and normally adenosine does what to the heart? Yeah, so when we think about adenosine, we're giving it for SVT, we want it to stop the heart, and then allow it to kind of reset itself, and then you come back, and hopefully you're kind of back in normal sinus rhythm here. So adenosine typically is kind of like a major kind of like, I talk about GABA as being the brakes on the system. I think of adenosine kind of like as the emergency brake on your car, right? So it kind of stops everything. which in the case of, say, something like the brain, it has a similar inhibitory sort of effect there. So if you see something like inhibition of adenosine, you typically will find an excitatory sort of effect, which makes sense why we give caffeine to these kids, and you actually see an excitatory sort of effect. This also has some ability to do things like cause bronchodilation. And in fact, we used to use caffeine as a bronchodilator to help out with patients with asthma back in the day. We don't use it too often anymore. But also when we talked about asthma, what drug is this very structurally similar to? Not phenytoin, that's for seizures. Theophylline, right? You can see how some of these names can be pretty similar to one another. Phenytoin, theophylline, the pH in there. Yeah, so theophylline is going to be the drug that's in a similar category as this. We call those methylxanthines. Anyone know what candy also has a methylxanthine in it? Actually, chocolate. Chocolate has theobromine in it. It can be converted over into caffeine eventually. That's why caffeine will give you, or chocolate will give you a little bit of a boost. It's not only just the sugar content, but it's also the theobromine in that. It's also why dogs can't have chocolate, because they can't process the theobromine appropriately. So anyway, so by acting as an antagonist, you're going to typically find this is going to cause stimulation. And again, how many of you are abusing caffeine right now? Right, so probably the majority of you. It's okay if you don't want to own up to it. That's fine. I understand. But yeah, so I guess abuse is probably a bit of a strong word. Maybe using it to facilitate your learning. I'm sure I think much more likely to raise your hand. But anyway, right, because of the stimulatory sort of aspects there. Now, if you take it to an extreme, what do you think caffeine could do? Get way too much of it. Seizures, absolutely, right? Because again, you're inhibiting adenosine, so you can actually find seizures can develop there. And if I'm inhibiting adenosine on the heart, what do you think that can cause? Arrhythmias, absolutely. So supraventricular arrhythmias are common as well for patients who are abusing caffeine, right? So for instance, I mentioned liquid forms of caffeine, like your Monsters Energies or your Rock Stars and things like that. Typically they have a lot of caffeine in them, but you have to drink so much volume that it's hard to really get to really serious overdose territory. But with like caffeine, like tablets and things like that, like no dose, that's where you run into big issues, because it's very easy to get a very big dose all at one time. Anyway, though, but you can see things like palpitations, tachycardia, so again, caffeine tends to be very stimulatory. And again, you are all probably very familiar with the effects of caffeine, but here we're using it for the stimulatory effect on the respiratory drive, okay? And so also notice here, you don't have to memorize the dosing, but notice we have both PO and IV options that are available for these kids here. And normally we'll start them off with the loading dose. And what's the benefit of a loading dose? You're right at steady state right off the bat, right? So you give them a big dose to try to build up the body levels, and then you give them maintenance dosing afterward to try to maintain them there. Okay. And again, your goal is always to switch from IV to PO or PO to IV. What do you think? Always want to go IV to PO if you can, right? So again, as these kids are getting a little bit more self-sufficient, then eventually switch them over to PO, and then eventually wean them off of it.
It says 40 milligrams per kilogram. When a cup of coffee is like 80 milligrams. So that's a lot of caffeine.
It's a lot of caffeine, isn't it? Yeah. Yeah. So normally I think like a normal cup of coffee, and again, it varies wildly depending on where you're getting it from and how it's made and all of that. I usually think like 135 or so, like a typical cup of coffee. Maybe you're drinking the weak stuff. I don't know, man. Anyway, just kidding. Yeah, so again, if you're doing, say, 20 milligrams per kilogram, now normally these are premature kids, right? So how much are they weighing typically, you think? Could be 1, 2, 3 kilograms, right? So again, these are pretty small little peanuts here, because again, they're born premature, they're probably underweight, they're probably not going to be, kind of stimulating a respiratory drive. So that's, yes, it is a very big dose. Imagine if you were taking 20 milligrams per kilo, that's a lot of caffeine, right? But again, you're using it for the stimulatory sort of aspects there, right? And they tolerate it pretty well. So, and that's just a one-time dose, right? So you load them with that, and then you start them off on the maintenance dosing. Okay. Very good point there, yes. So, I mean, I guess we could give them PO coffee, but I just imagine like little neonate kids just trying to drink a cup of coffee in the NICU, but might help with their temperature stability, right? So you don't have to turn on the little easy bake oven for them. But anyway. All right, so cystic fibrosis is another topic I want to hit on, because there's a lot of new drugs here that we haven't covered before. But what is cystic fibrosis? You covered it with Dr. Nicholson yet?
It's like an excessive amount of like thick mucus in the lungs and anywhere else, like intestines.
How do you describe that mucus? What are some good words to describe it?
Viscous.
Viscous. What else? Tenacious. I love that word for the idea of mucus. Like, I think of you guys being like tenacious, because you're working through PA school and this is really hard. This is tenacious sputum, right? So again, think about this really thick, very difficult to clear sort of stuff. Why did they get that thick mucus? The DNA problem, right? So this is a genetic condition here. But basically, what's happening is, and this is a very common, or relatively common life-shortening sort of a genetic disease, and especially in Caucasian in the U.S., typically the most often we're going to run into that. And again, this is one of those things where it's very common to have patients who will carry one of these alleles, and it's recessive, so they can be carrying it, not know it, you pass it on to the kid potentially. So you have these carriers there that are there because it is autosomal recessive. But problem is that they have this issue on chromosome 7, where basically they are not able to develop the CFTR channel here, right? So this is a chloride channel, cystic fibrosis transmembrane conductance regulator. So just know that this is really responsible for sending chloride through this channel here. Okay, so we're not able to process chloride across biologic membranes very well. And so you're going to find the different mutations. The most common one is delta 5 FO8 mutation. You're going to see this in the majority of kids and again, they'll have this genetic testing done typically at birth, and they'll determine what sort of mutations they had there. And this could be important depending on what type of medication you're going to use a little bit later on. Some of them only have an indication if they have this specific mutation here. But basically, you're going to find that the CFTR channel is going to reside in these apical membranes, and they're responsible for sending chloride across. And again, chloride, think ions going across, what's going to follow those ions? Like I mentioned, like where salt goes, water wants to follow, right? So again, if part of salt is going to be chloride, if that chloride is not flowing, water is not going to flow either. Okay, so you're developing this mucus, but there's no real good water content to it, which is why it gets so viscous and gets so thick. And you think about it mainly affecting the lungs, but it can affect a lot of other organs as well. A lot of exocrine organs can be affected. Things like, the vas deferens, the sweat ducts, things like the pancreatic ducts, all these can be affected, right? So again, it's one single mutation that's affecting organ system, basically the entire body wide. And we'll talk about different ways we can target this. And again, these are patients who their med list is going to be 12, 15 medications long, no problem, because of the different manifestations you're trying to treat here, right? And so what you can find is that fluid secretion is insufficient. They're still producing the mucus, they're still producing those proteins and things like that, but there's no water content to it, so it gets very thick and it will start to block up things, right? So for instance, with like the pancreas, it'll block up those ducts, and a lot of pancreatic enzymes. What do you think happens to the pancreas when they're kind of just chock full of all these enzymes and they have nowhere to go? They start to digest the pancreas, right? So that can lead to things like diabetes, right? We're going to find things like they can't release those enzymes, so food doesn't get absorbed very well. We're going to find that they can't sweat very effectively, so things like heat transmission is not going to be very good, or things like that. Anyone know how they used to test kids for CF? Like lick a baby and see if they're salty, and then you determine if they have CF, right? I don't recommend licking many babies. Even if they're young, it's just weird, right? But yeah, they get this kind of frosting of the skin because, again, they have a lot of that salt that's there. They don't have a lot of ability to actually, have the fluid go along with it there. Anyway, so, but again, a lot of the drug therapy we're looking at is going to be focusing on kind of dealing with the manifestations here, either replacing things that they can't produce on their own, or just treating otherwise the different kind of sequelae of having all these sick, tenacious secretions, especially the pulmonary sort of complications you're going to see with this. So anyway, so again, we're going to find decreased sodium and chloride permeability, so less fluid is going to be going across those membranes. That's kind of the big thing we're shooting for there. Again, is thick, desiccated. Again, desiccated just means what? Very dry, right? You think about like a mummy is being desiccated, right? Think about very dry, not like my mommy, but a mummy, right? Very dry, desiccated. Kind of secretions there, right? So again, what do you think happens? All those secretions are sitting there in the lungs. What do you think is going to happen with that? Because normally we're trying to always move stuff up and out of the lungs because we want to keep the lungs what? Sterile. And if we don't have that movement and stuff, what's going to happen? Going to get infected, right? So this is a huge reason why a lot of these kids end up getting admitted to the hospitals, because they're developing these pulmonary exacerbations. A lot of it's related to the bacteria that are starting to grow there. Okay. So anyway, as I mentioned, lung disease is accounting for 95% of that morbidity and mortality. So most of the time these patients get infected with something that we don't have enough antibiotics for, or the right kind of antibiotics, we'll find that resistance is a big issue here. And this is what usually leads to their demise, right? A lot of patients may try to seek out things like a lung transplant, either may not be able to have a good donor, or potentially they don't make it that far. But actually what we're finding out is the drug therapy, we're getting a lot better with this, and these patients are living a lot longer nowadays, which is great. So for instance, like my wife was working over the weekend at ORMC, and usually in an adult hospital, how often do you think you run across CF patients? Not very often, but she had actually like a 20-year-old who was there, who was a patient, and so it was like awesome. Like actually lived long enough to make it outside of the Peds system, is now having to deal with adult patient, having to deal with in the adult realm, and it's great because like my wife was like, well, I have no idea how to do amikacin dosing for this patient because they're trying to use all these Peds protocols, and I'm used to adult stuff. Adult stuff is easy. I got to start dosing like Peds. I'm like, oh yeah, just do this, this, and this. She's like, shut up, I know you know how to do that. I had to figure out how to do it. Anyway, so again, it's nice these patients are living longer. You're going to find that you may be dealing with more of these patients in early adulthood, which is great. Anyway, so as I mentioned, with the dehydrated, tenacious respiratory secretions are going to be able to harbor a lot of bacteria. They're not going to be able to clear that stuff out. So a lot of therapy we're going to be looking at is trying to try to moisturize that. I guess maybe not moisturize is the right word, but try to incorporate more fluids into it, try to break up that mucus so that it can clear more easily, and also do with a lot of the bacterial overgrowth that's going to be happening there. Also, when you have all that mucus there and you have all this bacteria that's growing there, what do you think your immune system is going to be doing? It's going to be overactive, right? So you're going to find that the immune system, typically they're pretty kind of, overall their inflammation levels going to be higher than someone who did not have CF, and so that's another thing we're going to be focusing on with some of our medication, try to deal with it from an anti-inflammatory sort of standpoint. Anyway, so those are the main things we're going to focus on. And again, if you had to imagine a normal, say, lung cell versus a patient with CF, you're going to see here they get these mucus plugs. And so again, if there's a bacteria in there, they're free just to sit there and kind of replicate and kind of cause a nice little infection there. And you're going to get all this inflammation surrounding it, causing worsened lung function over time. Imagine someone with chronic CF versus someone who had no CF there. You're going to see, again, it's very inflamed. A lot of issues there as far as like oxygenation going on because all those alveoli are going to be blocked up, etc. Right? So again, this is the main focus for a lot of times these patients get admitted for CF exacerbations, usually for lung stuff, and they're usually in there for a while because it takes a while to kind of rehabilitate the lungs to kind of get them back to baseline. And again, oftentimes this will kind of develop into this kind of a recurrent infectious bronchitis. And what kind of bacteria do you think are going to be growing there in these CF lungs? I heard it. Pseudomonas. Is there a snake loose in the room? No. Pseudomonas, right? Yeah. Pseudomonas aeruginosa is going to be one of the biggest kind of culprits as far as these respiratory infections go. So we're going to find that's already going to dictate what sort of antibiotics we're going to use. And again, if I'm having to treat these recurrent, because they get colonized, right? They get colonized all these different bacteria. And if I'm recurrently treating with antibiotics, what happens to those bacteria over time? They become more resistant, right? And so it eventually get to a point where I don't really have a lot of good options as far as antibacterial therapy go because it's resistant to almost everything, right? And then they start to get some of these opportunistic infections that start to crop up here. Things like Stenotrophomonas multifida, things like Burkholderia cepacia, things that if you see that, you typically know it's probably someone who is kind of a little bit more progressive sort of CF, because if they're developing these infections that we normally can fight off pretty easily, it shows that they have pretty significant lung disease going on there. So, and again, we'll talk about the different types of organisms, but certainly not just things like Pseudomonas, but things like Staph aureus have a propensity to grow in there. We have things like H. flu, obviously. All of your normal respiratory bugs can be potentially making a show here. But again, think about things like Staph aureus. Think about things like Pseudomonas. And then again, when you get these late emerging organisms, typically they're more progressive, usually later on in the disease course. And again, these are the big ones that you kind of, once you see that, then you kind of know, okay, yeah, something, this patient's pretty sick. But again, things like Aspergillus, right? Fungal infections you can also see. That may be prohibiting a patient from, again, the patient my wife was dealing with was, they're actually on the list for transplant, but they actually had to get back to baseline before they could even make it to the hospital, right? So they're having to deal with the fungal infection they had going on, the bacterial infection, all this other stuff going on before they could even get the patient moved over to actually get the new lungs in there, right? To actually fix the ultimate problem before that patient was in the hospital in the first place, right? So anyway, so when looking at Pseudomonas, there's two main phenotypes you're going to run into. There's non-mucoid and mucoid. Which one do you think sounds worse? Mucoid just sounds grosser, right? So mucoid is definitely worse, and patients will develop this. So again, this is something that will be reported out on the sensitivity when you culture it out, and it'll say mucoid forming, Pseudomonas aeruginosa. And so basically what that means is it has this nice kind of like wall it's basically surrounding itself with. It makes it much more difficult for antibiotics to penetrate it. More difficult to penetrate, it's more difficult to kill off. You're going to find that, again, this is a big cause for resistance in these patients here. So as I mentioned, oftentimes we'll get these acute chest infections or these acute exacerbations that will end them up in the hospital here. And so typically they always have kind of baseline lung dysfunction, but usually they'll either get a cold or they'll get some sort of inciting event that will kind of tip them over the edge. That's exacerbation, they'll end up in the hospital. And again, sometimes when they end up there, it could be there for weeks. 4 to 6 weeks is not uncommon for these patients to basically be kind of setting up shop in these hospitals here. And so usually they'll get what we call these tune-ups. Like you think for your car or something, but it's trying to get your patient back down to baseline essentially, right? So a couple of weeks of intensive antibiotic therapy or using a lot of lung clearance sort of techniques to get them back down to baseline lung function, and then they can kind of go back and hopefully go back to a normal sort of life with them. Some of the other disease manifestations here are going to be the GI effect. So again, how do you think this might affect the GI tract? Yeah, so you can see things like constipation, right? Because they don't have good secretions to be able to lubricate the stool to pass us. So constipation is a common manifestation there. You mentioned malabsorption. So you have a lot of issues with malabsorption. So that also goes back to the pancreatic dysfunction that occurs here, right? So if the pancreas can't release things like digestive enzymes, then what are the three main categories of enzymes the pancreas is releasing? You guys remember? Which are three main macronutrients? Carbohydrates, proteins, and lipids, right? So the enzymes that go along with that is amylase is for what? For carbs. What else? Lipase is for lipids. Use some sort of protease, right, for the proteins, right? So again, usually you see a pancreolipase. You normally find these are things we have to supplement for the patient because they can't release enough on their own. Okay, so because of that, you're going to find, and again, protease is kind of a broad category. You find there's many that fit underneath that, but because they can't release that, it's going to lead to malabsorption of several things. So again, if they don't have the lipase there to break down the fats, where all those fats stay in the GI tract, and they come out as what? Pretty significant diarrhea, right? So you're going to get these kind of malodorous stools, which I mean, stools are normally malodorous, but if you have a high fat content, it kind of makes it even worse. You're going to find that, I think what else? Some of the big things there. They have bad absorption of things like fat soluble vitamins, right? Because if they can't break down things like, what are our fat soluble vitamins? A, D, E, and K, ADEC, essentially. They have malabsorption of that, so that can lead to chronic, nutritional issues. And so these are things we're going to be supplementing. You sort of see how this med list is already starting to build up a little bit. But again, this is a very common thing you see with this, and oftentimes they're going to have that meconium ileus that occurs there because, again, they can't process that first stool in those when they're first born. They also have a lot of reflux. Esophagitis is very common for these patients because, again, things are not being processed appropriately. Hypoproteinemia, because they're not going to be able to process proteins very effectively, etc. So again, I mentioned here, the fat soluble vitamins are not going to be absorbed as well. So you can see things like neurologic dysfunction due to vitamin E deficiencies. You see things like hyperthrombonemia due to vitamin K deficiencies. So bleeding may be more a risk there. So again, these are things you're going to have to supplement because the patient's not able to process it themselves. I mentioned there's a biliary cirrhosis that can occur here because typically you're going to have this biliary sludging, and oftentimes we're going to have to supplement this by giving this ursodeoxycholic acid or ursodiol. Anyone know, when you see urso, what animal that denotes? I think ursa minor, ursa major. Bears, yeah, this actually comes from bear bile. Again, why remember these odd facts? I don't know, but now you have to remember it too. Not because I'm going to test you on that specifically, but just because now this little fact's going to stick out in your mind. But if you see ursodiol, that's basically bear bile that we're administering, or now it's synthetic, but that's originally where the product came from, where we can use that in order to help to break down some of those fats and whatnot, because again, they're not able to secrete these bile salts on their own, right? And so these are common manifestations there, and again, you can even have things like chronic appendicitis, et cetera, that will manifest because of the GI issues. As I mentioned, the pancreas, they're going to develop some sort of pancreatic dysfunction. So again, that can either be through the endocrine or the exocrine functions there. And so this is going to lead to things like malabsorption, maldigestion, et cetera. These bulky, greasy stools. So either they can be constipated, or if that fat content is not being absorbed well, you're going to find that it's going to be eliminated in the stool. That causes a lot of diarrhea. Weight gain is going to be inhibited, so typically these patients are underweight for the most part, and you can even find that you can have diabetes related to this, because again, if you have all these digestive enzymes, they're not being secreted out of the pancreas, they're just sitting there just kind of chewing up the pancreas itself. All those beta cells get eaten up, you don't have any insulin to release, and you induce type 1 diabetes in these patients, right? So hyperglycemia is a common thing, so you'll find a lot of these patients end up having needing to be put on insulin supplementation because of this, right? Because again, they're not able to secrete their own insulin because you destroyed those cells there, and so you have to be able to supply that exogenously, right? Now, how do we have to give insulin? Yeah, usually via injection, right? Subcu is the most common way because again, it's a protein, so it's going to get torn up by the GI tract anyway. Okay. Oftentimes you're going to find sexual development is going to be delayed there. Usually males are going to have this atresia of the vas deferens because again, all the secretory products are not going to be able to process very easily there. So again, infertility is pretty common to see with those patients there. Females may develop things like amenorrhea, et cetera, because again, they're just not processing things appropriately. Let's see. And I mentioned the sweat glands here. You're going to find that, especially during the warm weather, they tend to not be able to evaporate heat very well, or to get rid of heat very well, because again, that fluid's not going to be crossing, so you get that kind of frosting. You have this kind of sodium kind of glaze on the patient essentially, but no fluid's going to go along with it, so they're not able to really get rid of that heat very easily. And again, oftentimes I do not say you should lick your patients, because again, it's just bad form, especially on the first meeting. At least wait till at least a couple meetings in before you're going to try that, okay? Anyway, so again, education will be super important for these patients. They need to know they're going to be, frequent flyers in the hospital system. They're going to have these exacerbations, know how to try to find ways to try to avoid these, make sure you're immunizing them appropriately, things like the flu, etc. Right, so you want to keep them up to date on that stuff. And we're going to find that hydration is going to be really important here, because typically when they come in, they're going to come in very dehydrated for the most part, usually due to several issues that could be related to this. We're going to find that by keeping them hydrated beforehand can oftentimes keep them out of the hospital potentially, because again, it's going to help to kind of keep those secretions a little bit more hydrated, maybe so than they would be otherwise. And oftentimes you're going to find they're going to need a lot of IV hydration therapy once they actually get into the hospital system. And so our goals here, main thing we're going to be focusing on, try to keep them stable as long as we can, is one, to prevent lung function deterioration. So we're going to find there's a host of drugs we're going to use for that. Try to prevent poor nutrition. We'll see some drugs that are used for that as well. And then obviously we're going to be doing thorough pulmonary histories. We're going to be doing a lot of PFTs for these patients to see how they're kind of progressing. Okay, so for the pulmonary aspects, for the treatment goes, things we want to do is try to clear the secretions and then control the infections. Okay, these are going to be big things we're going to be focusing on from a drug standpoint. It's also going to be chest physical therapy. What is that? Basically just doing like a gorilla kind of thing, right? Try to loosen up the secretions so that way they can try to process them a little easier. There's other things we can do. There's like vests that they can put on. So called chest physiotherapy, where basically the vest will kind of beat up their chest on its own to help them secrete that. Oftentimes you're going to find that, especially as these kids develop into teenagers. Now again, think back to when you guys were teenagers. Some of you are not so far removed from that. Where you want to listen to your parents and they say, you need to do this every single day, multiple times a day, where you're like, yeah, absolutely, I'm going to do that. You're probably like, no, I don't really want to do that. It doesn't sound very fun. Right, so again, oftentimes compliance can be a big issue, especially as they become teenagers. They don't want to be compliant with their therapies because, again, it's a huge hit on their quality of life. They're having to take medications all the time. They're having to do the CPT all the time, the chest physiotherapy. So that oftentimes can lead into exacerbations for these kids as well. But we'll look at inhalational therapy and then antibiotics for them. Okay, as I mentioned, CPT is either going to be done manually, could be done with a chest vest that'll actually do it for them. It's kind of a hooked up to like a power pack and will be able to kind of manually percuss the chest. And again, they're doing 1 to 4 times a day. So again, it takes a period of time for this to occur. It's not like it's just one big beat and all of a sudden all the mucus is clear. It's going to take 15, 20 minutes, potentially 30 minutes to loosen all that stuff up. But we do know that if they stop doing CPT, you're definitely going to see a decline in lung function, because all that mucus is just going to stay there. It's going to get infected, and that's going to lead them to an exacerbation. Okay, so let's look at the actual drugs we're going to be using here. So one of the things we can do is try to use aerosolized antibiotics. So what do you think is the benefit of aerosolizing antibiotics? Speak up a little louder so I can hear you. Don't be scared to be wrong. This is the best place to be.
Goes to the lungs right away?
Yes, thank you. Goes to the lungs right away. So what do you think it does to our concentrations in the lungs?
Pretty high.
Very high. Thank you so much. Great. It's going to be just a dialogue between us for the rest of the class.
You have made a mistake.
You've made a terrible mistake, yes, sir. Right. So you get very high concentration in the lungs. What does that do to the systemic exposure? It decreases it pretty significantly, right? So again, the benefit there is you're getting a lot of drug all at the site of where the actual infection is, which is great. You're also going to find that it's going to limit the systemic exposure. And again, what kind of drugs do we talk about are good for Pseudomonas? Aminoglycosides, or aminoglycosides is very good from a systemic standpoint. Not great, right? Again, because they can lead to ototoxicity, nephrotoxicity. We didn't like them from that standpoint. But if we can just aerosolize them, you can breathe them in directly, and they can get very high concentrations. That can be very useful. Now, again, we're going to talk about the ordering of these products here in a little bit, and I want you to think about the order of how you're going to do this. When do you want to give the chest physiotherapy versus the antibiotics versus the bronchodilators versus all these other things? We'll talk about that in a little bit, but we'll start to think about those sort of things as far as ordering them to how you make them most effective. Okay, we want to get the most bang for our buck here. Anyway, so we know these are good because they're going to help to improve pulmonary function. Also, a lot of these drugs are not available orally. So if I can give them via nebulizer, it's very easy to do at home, right? They can administer it themselves. That's no problem there. So the most common ones we run into are going to be tobramycin. There's actually a nebulized form called Toby they can administer patients for themselves. And oftentimes what they'll do is they'll do a month on at a time, and they'll take a month off. They'll do a month on and then a month off, right? The idea there is try to give, try not to give them constant exposure to the bugs to the antibiotics, because again it helps to limit some of the resistance you can develop there. So the idea is you do 28 days on, 28 days off, and kind of vacillate between those two. You do things like cholestyramine or colistin, ceftazidime. Ceftazidime is what kind of antibiotic? Third generation cephalosporin, right? Remember what did I say about ceftazidime and using it for Pseudomonas? There's a big resistance rate. Like, we didn't really like to use it from a systemic sort of standpoint, but why can we use it via the inhaled route? High concentrations, right? Again, resistance is always a matter of concentration. I can give enough drug to kill any bacteria, but you worry about the toxicity is going to happen to the patient, right? That's usually what limits how much you can give. By using it inhaled, I get very high concentrations, really no side effects to the patient there, but I can overcome that resistance pretty easily. So inhaled ceftazidime is still used occasionally, but most often you're going to find tobramycin, amikacin used, and the aminoglycosides can be used from that standpoint. Now again, is that going to cover any of your gram-positive bugs? It will not, right? It's only going to cover your gram-negative, so your Pseudomonas will get hit by that. You're going to find, things like your H. flu are going to get hit by that. But things like if they have a Staph aureus infection, it's not really going to do much for it. Okay, so just kind of keep that in mind. Now, some other things we can do are try to break up the mucus, right? What do you call that when you break up the mucus? Mucolytic, right? So we can use mucolytics to try to lyse up that mucus. And so one way we can do that is by using a drug called pulmozyme or Dornase alpha. Again, this is a very expensive product because it's a protein, but then we're going to nebulize this. They'll inhale this, and what it actually does is a DNA enzyme, right? So it's actually going to break up some of the DNA in the cells within that mucus and make it a little bit more less viscous, essentially, right? It's going to break it up. It's going to allow more water to kind of get incorporated there. It's going to make it easier for the lungs to clear. Now, to think about it, would I want to do chest physiotherapy before or after I gave them a dose of pulmozyme? After, right? Why? Exactly right. Once you give your mucolytics, it's going to be easier for that mucus to clear, right? If I did chest physiotherapy beforehand, all that mucus is thick and doesn't want to move anywhere, and it's not going to be as effective, right? So I want to use mucolytics typically before you use your chest physiotherapy. Okay. When do you think you want to use antibiotics? Probably last, right? Because again, you want to make sure you clear all that mucus, get rid of any of that junk that's in there, whatever you can, and then give the inhaled antibiotics. That way you have as much surface area to cover with those antibiotics and get as much penetration of those bugs as you can, and hopefully try to eradicate them, right? Now again, these patients, once they're colonized, typically they're colonized for life. It is very difficult to actually eradicate these pseudomonal infections from these patients, but we do the best we can to try to keep them at bay, try to keep the patient out of the hospital, right? Anyway, but the big thing here is just very, very expensive because it's a recombinant product, protein we're having to make, so it's something to keep in mind there, right? Again, the big thing here is going to help to limit some of those exacerbations from more mild to moderate lung disease for those patients there. What are some other things we can do? Well, there's some cheaper stuff we can do than just pulmozyme, and so oftentimes you're going to find these being used in combination. So one thing we can do is hypertonic saline. When I say hypertonic, what does that mean? Yeah, very high concentration, high osmolarity, right? So higher than the blood, essentially, right? So again, we're always talking about in relation to the human serum, okay? Normal blood osmolarity is what? You probably should have had this in nephro, right? Did you talk about this with Dr. O? Perhaps. 300, yeah, 280, 320, somewhere in that range. I usually use 300 is a pretty good number to keep it in that range, right? So 300. What is isotonic saline? What concentration is that? 0.9%, right? 0.9%. Does anyone know how much sodium that is per liter? How many milliequivalents? 154, right? And again, sodium chloride breaks up into sodium and chloride. So 154 of sodium plus 154 of chloride is what? 308. Is that pretty close to human blood? Yeah, pretty close, right? So again, that's why I call it isotonic. Shouldn't cause any fluid shifts here. By giving hypertonic saline, we said 0.9% is isotonic to the human blood. Now we're using 7%. So it's over 7 times more concentrated sodium chloride. So by kind of infusing this mucus with all this sodium chloride, what is that going to cause water to do? It's going to draw water out into the mucus there. So it's going to help to make it much more easy to clear. It's going to increase that water content, and it's going to be able to, and we call that rheologic properties, right? by making it flow easier, it has better rheologic properties. Okay, and so by doing that, it's going to allow the mucus to flow a little easier, have more water content to it. It's going to be able to easier to be clearing when you're doing your chest physiotherapy there. Okay, so aid the transport of mucus there, hydrate the airway surface, help with that mucociliary clearance. Okay, and again, you may see 3% being used sometimes, you may see 7% being used. These are common concentrations of the same user. They're doing the same thing essentially, right? But again, by having a high concentration, it'll draw water in. Now, similarly, if I had someone who, say, for instance, had a head injury and they were having cerebral edema, and their brain was starting to swell up with fluid, I could also use something like hypertonic saline, get that into the blood, and that's also going to do what? It'll draw water out of the brain into the bloodstream, and then that pressure is going to go down, and then you just pee out that extra fluid, right? So again, think about how things are going to shift when you're using hypotonic versus hypertonic versus isotonic fluids there. We'll talk about this more when we get to the nephro section later on. Okay, so just something to think about. So, as I mentioned, the pulmonary exacerbations, typically they're going to need 2 or more weeks of therapy here. Usually more than that is what I end up seeing. Patients are usually in the hospital, say 3, 4, 6 weeks potentially. And we're using our maximal doses of antibiotics. So one of the nice things about CF patients is for all their organ dysfunction, we typically find the kidneys work perfectly. They have great functioning kidneys, which means they chew through antibiotics very well. Okay. Which also means we have to use very high doses in order to overcome that, because we know their clearance is going to be so high in those cases there. And so typically what we're going to use is our antibiotic therapy. We'll talk about the different drugs we're going to use here. The biggest thing you can do is to look at their previous cultures and sensitivities. Why is that? Because if they're already showing me they're resistant, the Pseudomonas that they're growing is resistant to gentamicin, am I going to use gentamicin on that patient? Probably not, right? I'm going to move to something else. So you have to think about what have they done previously, what has been intermediate or resistant, and usually shoot for something else than that, right? You want to shoot for things they've been susceptible to in the past here, okay? And so again, looking at this, when you have their exacerbations, again, you're going to be finding they're going to develop this dyspnea, this increased sputum and cough production is going to be going along with this. And again, you can find some changes on radiographic findings, certainly on chest x-rays and whatnot. But again, they're going to know when they're having an exacerbation, because typically they've had enough to where they kind of know what it feels like, and they'll know when they need to come in typically. But looking at antibiotics, so if we can, we like to shoot for oral antibiotics before they have kind of full-blown exacerbation. If you can keep them out of the hospital, that's always going to be great here. And so in those cases there, again, looking back at previous cultures, what they've grown previously, we can try to focus on some of these things there. So for instance, if they have a history of Staph aureus, well, what are some things we can use to try to cover that? Well, certainly are things like anti-staphylococcal penicillins can be potentially useful. Now again, dicloxacillin is only going to work on what kind of Staph aureus? MSSA, right? It's not going to work for MRSA. What could I use if it was an MRSA? Bactrim could potentially work. Clindamycin's a good one, right? And so again, you're going to find some of these are going to be incorporated in, but it depends on if they have a history of MRSA or MSSA. Okay. For things like H. flu, things like amoxicillin, augmentin, any of these are going to work just like they would for a patient without CF. But again, shoot for those maximal doses there, right? It's like a normal dose of augmentin. You guys cover that with Dr. Nicholson? Like 90 per kilo per day, right? Is usually what we're shooting for. Again, usually when we're talking about peds, like we're just focused on the milligrams per kilo per day, or per dose as the drug may dictate. But again, because depending on the size of the kid, that dose is going to change there. But by shooting for the milligrams per kilogram, you know what your goal is. And then for Pseudomonas, things like ciprofloxacin can be potentially useful here. And then the inhaled antibiotics are also useful as well. Okay, so again, these are things to try to keep them from getting into the hospital. But when they end up in the hospital, you got to switch over to IV antibiotics here, and so you want to treat Pseudomonas, and again, you don't want to treat your physician's assistants with 2 antibiotics. You want to treat your Pseudomonas aeruginosa. It's just unfortunate you guys share that acronym, but treat Pseudomonas aeruginosa with a minimum of 2 antibiotics. And again, so we need 2 anti-pseudomonals. So what classes can I use there? So is there any penicillins I can use? Zosyn, right? Zosyn is what? Yes, it is an anti-pseudomonal beta-lactam, right? But what drug is it? What's the generic? Piperacillin, tazobactam. Fantastic. Thank you. Yes, piperacillin, tazobactam. Tazobactam is what? Beta-lactamase inhibitor, right? So again, that has no actual function on killing the Pseudomonas, but piperacillin does. It just helps to keep those beta-lactams from breaking down, beta-lactamases from breaking down the piperacillin, right? Good. What carbapenems could I use? Everything but ertapenem, which includes meropenem, imipenem, Doripenem could also be used as well, right? How about cephalosporins? What's the main one we're going to use? Well, which third generation? Because I can't use Rocephin, right? Rocephin won't cover it. Ceftazidime does cover it. In some cases, we actually have some. I probably wouldn't jump to that first because I do worry about the resistance issues with IV ceftazidime. But we have some kids who that's what they respond best to, right? Based on the cultures and sensitivities, that's just what they go to. So sometimes we'll use that. But what else could I use? Cefepime, right? The fourth generation cephalosporin. Cefepime is going to be your go-to anti-pseudomonal cephalosporin, right? Some newer ones, but that's the main one I want to focus on. How about aminoglycosides? Any of those will work, right? Amikacin, gentamicin, tobramycin, any of those are good. And in fact, some patients you'll actually find they'll be on inhaled and IV therapy. I should do both of them because again, you worry sometimes about hematogenous spread of bacteria from the lungs to other sites. Sometimes by shooting at it from both, both inhaled and IV, sometimes you get better penetration into the lung tissue. So you might see that occasionally. Any other drugs? How about fluoroquinolones? Levofloxacin, Cipro, moxifloxacin. Can I use that? What could I not use moxifloxacin for? No, I could use it for lungs. Could use it for UTIs. Remember that was the one that gets only metabolized in the liver and it has no effect in the bladder, right? All those little things you got to think back to, right? Anyway, right. So those are the big ones here, and again, I had most of these already on the slide. You guys should be able to come up with most of those. I'm just kidding. Anyway, I know most of you guys aren't reading the slides anyway. Really just focused on me, on having this interaction right now. It's fantastic. But again, sometimes you'll need a third antibiotic, and this again is dependent on what they're actually growing. So if they have Staph aureus, what are you going to cover that with? To go to IV Staph aureus coverage, MRSA, Vanco, right? Vanco should be first thing that comes to your mind. You're thinking IV therapy for MRSA, right? What else could I use? Linezolid, I could use that. What else? Bactrim potentially. Clinda, right? Any of those would be totally fine there, right? But usually Vanco is going to be your first go-to, right? Usually when you think like Bactrim and Clinda for Staph aureus, you usually think for like skin infections. For this case here, Vanco is going to be my go-to, right? And then things like Burkholder serpatia, that's where actually Bactrim can sometimes be used for those patients there. It's actually the drug of choice for that. Anyway, so again, depends on what they've grown previously. Because again, are you going to have cultures ready when the patient initially presents with those exacerbations? No, you're going to reculture them again. But you want to start off with therapy that's empiric therapy that's more guided based on what they've had before. Okay. And again, when do you want to get your cultures versus giving antibiotics? Cultures always first, right? As long as it doesn't cause any kind of meaningful delay. If his lab's like, oh, it's gonna be 2 hours so we can do a culture, like, that's no good, right? You need to start antibiotics for these patients. Okay. Now the thing is, we can, and again, don't get focused on it so much on the dosing specifically, but I just want to focus on how we're changing how we're going to be dosing this. And so we talked about things like aminoglycosides, and we can actually shoot for things like once daily dosing of these. Because if you remember, were aminoglycosides, are they time dependent or concentration dependent killers? They're actually concentration dependent killers. So for these patients, because I know the lungs are infected, they're colonized with this Pseudomonas or other bugs, you have to shoot for really high concentrations because the lungs, are they typically easy to penetrate or difficult? They're typically difficult to penetrate. Lungs are always going to be a little bit harder to penetrate. That's why if you're looking at things like vancomycin dosing, you have to shoot for higher dosing for that for the lungs, right? Because it's a kind of a protected site. You don't necessarily want to have a lot of drugs in there, so you're going to find that they're difficult to penetrate. Just like the CNS is difficult to penetrate, lungs are kind of behind that a little bit in terms of difficulty there. Anyway, so by shooting at really high doses initially, we get very high concentrations. And then what is your goal trough for something that is a concentration dependent killer? Because with a time dependent killer, something like say a carbapenem, what is your goal? What should your goal trough be? It should be above the MIC of the bacteria, right? So because again, by keeping above the MIC, you're preventing the bacteria from growing. With a concentration dependent killer, you have that post antibiotic effect, right? So again, the goal here should be a trough of, it can be 0. It's totally fine, right? Because so I can give them a huge dose, get the concentration really high initially, penetrate that lungs, try to kind of shock and awe essentially that Pseudomonas there in the lungs, and then the concentration will go down, and they can clear this stuff super easy. They'll get down to a level that is undetectable, and then you can redose them the next day. So typically we do Q24-hour dosing for these patients because they're able to clear it very, very well. And again, we're shooting for very high peak levels, but our trough should be undetectable. Okay. So again, know why, if you're looking at antibiotic levels, why we're shooting for a level that might be 0, that may be the goal, or we want a higher level, something like vancomycin potentially. Okay. All right, I'm turning my mic. any questions before we continue on? So some people were a little disappointed that my aluminum foil setup was disingenuous, simply using it as a lead into a wonderful pun. But actually have had some weird cases of foreign body injections like that. So we had one patient who presented to the ER for abdominal pain. And so unfortunately I don't have the pictures like saved up here or anything, but basically he's complaining of abdominal pain. He's coming from a psych facility and he ends up at the ER. So they do a KUB on him. And what do they find? They find this entire his entire belly basically, for one, it was like, instead of being up here, was like down here almost like to his bladder because it was so full of different metal objects he had ingested. Includes like nails, screws, pieces of jewelry, all kinds of different stuff. And his thought process was, well, when people want to get strong, they pump iron. So if I eat a bunch of iron, then I'll get strong too. And so I ate all this stuff up. And then, of course, we're just like, holy cow, because you just see this giant white mass in the stomach there. Ended up having to go to surgery, got everything pulled out. The guy did totally fine afterwards. I think his copper levels were a little high based on some of the stuff that he had ingested, but otherwise, he did totally great. No, there was a few of those. I don't know if you guys ever had Star Wars Monopoly when you guys were growing up, but the little figurines, he had actually eaten a few of those. So the Force was with him in one sense of the word. But anyway, yeah, so sometimes you'll see weird foreign body injections like that. There's cases where people have eaten like bullets before, especially patients like pica, you know, those eat kind of random stuff. So they've had like bullets they've ingested before. What do you have to worry about with bullets? Yeah, so in one case you have to worry, so if it's like a full cartridge, like you'd have to worry about potentially going off. So you have to be very careful with the scope. It's happened before. Well, I don't know if it's actually happened, but that is a concern theoretically of occurring. But more commonly, what do you run into with the bullets? Bullets are made of lead, right? So you got to worry about lead levels actually going up in those cases there. It's because the acidic environment in the stomach will leach lead off of there. And so other cases we actually have to monitor for that, right? There's one really good case report where the patient with autism and pica ended up in the hospital. His grandparents brought him in because he'd eaten like a plastic fork or something. And when they did the KUB, they ended up finding a bunch of like rifle casings that were in there. And so they had to go and pull those out. But the kid did have measurable lead levels. Normal lead levels, what? 0. Yeah, lead has no business being in the body. It's only a poison, if anything. And so they actually had to manage them with that. There's some chelation therapy the patient had to go on. Anyway, so getting back into CF, something that is closely related to foreign body injection. Not really. Anyway. So some of the kinetics actually change with these patients here. So we mentioned that, you know, based on the inability for them to kind of secrete fluids and things like that, you'll find some changes in their kinetics here. Also, their lean body mass typically is a little bit lower because they have this kind of malnutrition kind of chronically. And also, their lungs tend to cause this kind of reservoir sort of effect here, where basically it's this big sink for things to kind of go into. And so that can increase the volume of distribution for some of these drugs here, right? Which means it can be more difficult to really penetrate those tissues. You need more drug in order for it to penetrate into that big reservoir. Also, they have this enhanced body clearance, mainly through the kidneys. As I mentioned, the kidneys work very, very well in order to clear these drugs here. And so what you find is because of the altered volume distribution and the increased clearance, the drugs have a very short half-life typically, or at least ones that are a little bit more hydrophilic here. And so it's very difficult to get enough concentrations in order to be therapeutic, essentially. So you have to give these patients very high doses. You have to get to them very frequently in order to make sure you get the right concentrations there. And so that's why you'll find that patients with CF on much higher doses of antibiotics than you would see patients without CF typically. Now, some other things we can do as far as anti-inflammatories go, because we mentioned due to this kind of chronic infection they have going on, they're usually inflamed at baseline. We can use things like corticosteroids. These can be useful for some of the pulmonary exacerbations to work as an anti-inflammatory to kind of loosen up the bronchial smooth muscle and things like that a little bit. Things like ibuprofen are okay. But in fact, one of the things we'll actually administer is a macrolide, right? What's an example of a macrolide? Erythromycin, what else? Azithromycin. Clarithromycin. Yeah, usually azithromycin is the most common one. So if you ever see a patient who's on scheduled azithromycin Monday, Wednesday, Friday, they're typically using it as an anti-inflammatory. So some patients with other chronic lung diseases may be on this, but most often you'll see CF patients. Now again, why it works as an anti-inflammatory, I'm not really sure, because by giving Monday, Wednesday, Friday azithromycin, you're not really getting concentrations high enough to really kill any bugs. But it works as an anti-inflammatory, and that will slow down some of the degeneration of the actual lung tissue over time. So that's why you'll see that occasionally. Because again, what was another case where we used a macrolide for a non-infectious purpose? Erythromycin for GI motility, right? So macrolides are kind of weird because they have a lot of these kind of ancillary uses here, and this is another one of those examples. Now again, if the patient is on maximal antibiotics and they're still not responding, that's when we have to consider some of these other opportunistic infections. You got to start thinking about fungal things. You have to start thinking about atypical bugs, mycobacteria, and all those you have to start considering covering for potentially, right? So as I mentioned, the patient my wife was dealing with was on both inhaled and systemic amikacin to try to deal with pseudomonal infection. I don't know what else they're on from a bacterial standpoint, but they were also on voriconazole, which is an antifungal agent, because they had probably aspergillus or something that was growing in addition to that, right? So again, you're going to find usually multi-pathogen sort of infections going on for these patients, especially the more severe they get. Okay, so nutrition here, we're going to find that these patients typically have a higher caloric need, mainly because their work of breathing is always going to be kind of ramped up as compared to someone without CF, and just overall increased metabolic activity due to that kind of chronic inflammation there. And so oftentimes you're going to find that you have to have special formulas. They're going to be kind of having some of the pre-digested proteins and carbohydrates and things, so they can absorb it a little bit easier there. But typically they're going to have a high protein, high calorie diet with normal amounts of fat. Because we mentioned, are they able to process fats very easily? Not typically, right? Because again, they don't have enough of the bile salts to really kind of emulsify those. Lipase is not going to be released in the same amount. And so typically normal amounts of fat, but high protein to kind of help with that catabolism that happens on the kind of routine basis for them. And so we can replace their pancreatic enzymes. This is a very common thing you'll find for these patients here, where their replacements will contain lipase, protease, and amylase. And usually you're going to be basing this the dose off the units of lipase. And again, when you're writing units out like on a prescription or handwriting, how should you write that out? Should you write IU? What should you write? Just write units is fine, right? IU can sometimes be misread as 10. So even if you see something like fish oil or vitamin E or things like that, just write units is fine. You don't have to write international units, it's too much. Just units is good. But anyway, so you're dosing it based off the lipase here. And oftentimes what we're doing is we're changing the dose based off of their stool characteristics. So if they're still having these really kind of funky smelling, really greasy kind of stools there, well, then we know they're not getting enough lipase. We'll bump up the amount that they're taking, right? Now, when do you think these should be dosed? Do we give it to them like just once in the morning? Yeah, typically prior to eating, right? So we'll usually have, they'll be on orders, they'll have 3 times daily with meals. Dosing, and usually those meals are a little bit bigger, so they might get, say, for instance, a common dosing I'll see is say 4 capsules of, say, pancrease or Zenpep or one of these brand names. They'll get 4 capsules with meals 3 times a day, and then they'll have an additional order that's, say, 3 capsules taken as needed with snacks. Because again, these patients are on a high protein or high calorie sort of need there, so you're going to be eating a lot of snacks in addition to 3 typical meals, and so we'll give them additional doses for that. So anytime they're eating a meal, they should be taking in their pancreatic enzyme replacements in order to help them process those so they can absorb them more easily. Okay. And again, don't worry so much about the dosing here. Just know there are some limits to this. You can actually find, you can develop this fibrosing colonopathy and colonic strictures, which kind of makes sense because if you have all these enzymes there, eventually if there's so much of them, they can potentially start to kind of interact with the colon and start to kind of chew that up a little bit. So again, there are some limits to how much we can actually give there. And then sometimes what we'll do as well is give this along with a proton pump inhibitor or like an H2 antagonist, and that helps to increase some of the fat absorption as well. So again, if they're still having issues with fat absorption, you can add that on. And we already said they usually have a lot of issues with reflux anyway, so they'll probably be on one of these regardless, right? So what are some options we can use for that? It's like a proton pump inhibitor. Omeprazole, what else? Esomeprazole goes along with that. What else? Pantoprazole, rabeprazole, any of those are totally fine. How about from an H2 antagonist standpoint? No. Negative. Because what other CYP inhibitor might they already be on? Azithromycin, right? We talked about them being on Monday, Wednesday, Friday. Azithromycin, that's a minor 3A4 inhibitor. On cimetidine, it's another major 3A4 inhibitor. Start seeing some interactions. Thank you for illustrating a good teaching point, though, right? What are some other examples that we should use? Famotidine, nizatidine, ranitidine, any of those are totally fine, right? It's actually a good example. I had a really sick patient in the ICU yesterday. They were coming in, they were very complicated coming in, so I didn't get the full history on them, but basically they were coming for sepsis, being treated with a ton of antibiotics, but one of the things they ended up developing was esophageal bleed. Anyone remember what you used for esophageal bleeds? Octreotide, yes. We actually had the patient on an octreotide drip, and we also had them on what other drip do you think would be useful? What could irritate the esophagus? any kind of stomach acid, right? So you actually will put them on something like a proton pump inhibitor drip additionally in order to make sure you try to maximally suppress any stomach acid that could be interacting with the esophagus, could worsen that bleeding there. So they're on an octreotide drip, they're on a pantoprazole drip to help manage that. So it's a very common thing. You'll see that sometimes with variceal bleeds. You'll see that with any kind of esophageal bleeds. You'll just see octreotide being used as a continuous infusion. Okay. Anyway, so again, those are the things to consider as far as the pancreatic enzymes go. Now, looking at the vitamin supplementation, usually they're going to be on a specific multivitamin that is designed specifically for CF, right? So this is not just like your typical Flintstones chewables or something like that. They need to be on CF-specific products, or something like Aquadeck. Usually you'll find like ADEK right in the name there. Source CF, so you know it's for CF patients. You know that usually will give it away typically. And again, they have higher concentrations of A, D, E, and K, which we know they're going to have a hard time absorbing anyway, right? I mentioned for the biliary cirrhosis, we can give that ursodeoxycholic acid, or ursodiol, or Actigol is a brand name you're going to find. Ursodiol is a typical generic you'll run into there. And again, that's useful for helping to emulsify some of those fats and cholesterol and things like that they're going to be ingesting with their food. And again, this would be another one you want to typically give with a few meals throughout the day. Maybe not every single meal, but maybe twice daily, with breakfast, with dinner. That can be useful there as well. And then, of course, if you have end-stage liver disease, transplant is always a potential option for these patients. For the reflux, I mentioned, using proton pump inhibitors are going to be very effective for these patients. You don't want to use any kind of cholinergic agonist there, because that's just going to increase secretion. And if you remember back to your dumbbells, right, we know that cholinergic agents are going to increase secretion, so those are things we want to avoid for these patients here, right? So just be aware of that. And again, if you have a lot of, this reflux here as well, you can have this microaspiration of the stomach acid, and that could potentially cause some pulmonary exacerbations, which is why a lot of these patients are going to be on acid suppression therapy with the proton pump inhibitor most commonly. Now, some of the newer agents we have here, and there's actually a few more that have come out since this that fit in the same category, but this is a combination drug called Lumacaftor and Ivacaftor, or Orkambi, or Orkambi is the brand name here. And this is actually approved specifically for patients who are homozygous for that delta F508 deletion. All right, so again, we said that's the most common one. This is designed specifically for them. And so the drugs have kind of a dual mechanism of action. The Lumacaftor helps to actually increase the stability of that CFTR protein there, and actually helps to get more mature protein up to the cell surface, which we know they're missing. That's why they can't have that the chloride transmittance occur there. So by increasing the number of more stable proteins making it to the surface, they're going to be able to have better fluid transfer there. And then the Ivacaftor is actually going to potentiate the effect and allow for more chloride to flow through whatever CFTR proteins they actually have there at the surface, right? So one's going to make more proteins available, the other one's going to make those proteins work better, essentially. And so we'll take them with fatty foods that'll help to aid absorption here, and they actually find a lot of really good effects on just symptomatology. Like the lung secretions are going to be a little bit thinner. They're going to find that the GI effects are going to be less pronounced. It kind of works on everything essentially, because again, their pathophysiology is all based off the CFTR not being there, so you're basically helping it to work better, so it should be able to affect all these manifestations. Again, pretty well tolerated for the most part, but again, you may see rare hepatotoxicity, but otherwise it's a very well tolerated drug. And so again, looking at say the normal protein versus the defective ones in CF patients, you'll find that with Orkambi patients being treated with that, you'll have more of these proteins make it to the surface. They'll work a little bit better. They're probably not going to be at baseline like someone without CF, but it's definitely going to work a lot better than they would at baseline. Okay, any questions on CF? All right, so real quickly, we'll go through some GI disorders in children. We already covered GI stuff already. You're going to find that a lot of this is going to be very similar, so I'm not going to belabor these points too much, but I'll talk about some things that are more specific to children. Now, as far as looking at common GI complaints in kids, you're going to find, reflux, very common thing you're going to find, especially in premature infants. You find they tend to have a lot more reflux issues associated with them. A lot of recurrent vomiting can happen in some of these kids as well. Usually a lot of this will resolve spontaneously as they get a little bit more developed as they go on. For some kids, we're going to need some kind of more chronic therapy for them. So we're going to find for their GERD that it can be multifactorial. Sometimes it's actually a physical issue for them, where the lower esophageal sphincter is not working appropriately, and this is where you'll find there's some surgical things you can do, like the Nissen procedure can be used to try to overcome that, which I'm not going to talk about here. But again, you're going to find that in the meantime, we can use things like acid suppression therapy to help out with GERD symptoms for these patients here. And again, look at other things like, how's the peristalsis for the patient? Are they actually processing things through? You can find things like congenital heart defects and things like that that impair blood flow to the GI tract, may be playing a role here. So look at the other underlying issues, deal with those first, and then in the meantime, you can kind of help out with some of these acid suppression therapies. So again, for treatment of GERD in kids, it's going to be the same effects that we're looking for adult patients as well. And again, you're not going to find as much as like NSAID-induced issues here like you would for adult patients. You're not going to find nearly as much like H. pylori and things like that. So, but the drugs are going to be essentially the same for these patients. Obviously, dietary modifications are going to be a big thing. Also, proper body positioning during or after feeding can be very useful there as well. So again, you want to make sure you're not lying recumbent after feeding and whatnot. And then we'll talk about the pharmacologic therapy. Sometimes for infants, in order to have them help with their GERD symptoms, sometimes thickening of the infant's formula, so if you use like rice seal or something, kind of help things kind of stay down a little bit better, can help some of that reflux there. And if they're allergic to any components, using a hypoallergenic formula can also be sometimes useful there. And then for as the kids get older, into adolescent, you're going to find that by avoiding some of these trigger foods can be useful to help kind of mitigate some of their symptoms. So like caffeine, chocolate, things like that can be very useful, especially if you're given a bunch of food like right before bedtime or something and you lay them down. Obviously that can be problematic. Yesterday my wife was trying to make a cake and she had a thing of frosting left over. And what do you normally do with the thing of frosting before you throw it away? You get it all, and of course it was like right before bedtime, and my wife's like, "Oh, Lily, come over here," and she gave her like a big fingerful. And that stuff was like crack sauce to my kid. She was just, that was amazing. She kept coming back over, and she's like, "No, it's already thrown away." She's like, "Where's it at?" I said, "Thank you, right before bedtime. It's perfect. She'll be super wired for that." But yeah, so again, try to avoid any of those trigger foods if you're kind of familiar with what is a trigger for them. Now, any of these are going to work just as well as you'll see for adult patients. So proton pump inhibitors, H2 blockers, and then we're going to be fine. Now, as far as like the amount of evidence we have to use in kids, do you think it's lesser or more so than adults? Typically less, right? We don't have as much evidence for use of these medications as adult patients because is it easy to do studies in kids? It's very difficult, right? They're a protected class. And so because of that, it's a lot of it's kind of anecdotal evidence, right? So we try it in kids, see how they respond to it, and we publish that literature, and then we go from there. So it's not like we have randomized controlled trials for a lot of this stuff. So a lot of things we're going to use don't have specific childhood indications. And again, a lot of times if you look at the over-the-counter stuff, what age does it usually go down to as far as like recommending before it kind of stops recommending it? Kind of a bad way to ask that question. What's kind of the minimum age over-the-counter products will recommend for children? Usually 2 years of age, right? So anything under 2, what do they tell you to do? Go see your provider, right? Go see your doctor, go see your PA, whoever. Because less than 2, we don't have a ton of evidence there, and so they're trying to CYA a little bit, right? So they're trying to cover themselves from a medical legal standpoint. And then if they have any dosing above that, it's just kind of that's helpful, but you're going to find that we don't have as much evidence there. Does that mean anyone less than 2 doesn't need therapy? No, we just need to make sure we're kind of being a little bit more sensitive to that, make sure we're looking at things like their weight and all of that, and make sure we're kind of treating them appropriately. But again, look at the underlying issue. If the issue is peristalsis not being as effective, what can we give them to try to help stimulate that along? What can be a pro-kinetic sort of drug we can administer? So we can either use metoclopramide or we can use something like erythromycin, right? Those are 2 big pro-kinetic agents there. What's the issue with metoclopramide though? The dopamine antagonist, right? So there's some side effects seen with that, like EPS, tardive dyskinesia with long-term use, right? High dose long-term use. What else is an issue with metoclopramide? It's an anticholinergic too, if you think about it, right? Because again, it works as well, not only because it's dopamine antagonism, but also it's anti-muscarinic activity as an anti-nausea medication. So that can have some negative effects there as well. So if peristalsis is ultimately the issue, far and away we use erythromycin much more commonly in kids than we use metoclopramide. You'll find Reglan being used more frequently in adult patients, but definitely we use a lot of erythromycin for these kids here, right? What kind of cardiac dysfunction or abnormality can you see with a macrolide? Yeah, right. So we think about QT prolongation as well. Usually for kids, it's not a big deal as long as they don't have any kind of congenital issues. They usually don't have a lot of other medications that can exacerbate that. So usually erythromycin is pretty safe for those patients there, right? Again, remember our antacids. Where do antacids kind of fit into the role of treatment for GERD? Like everyday, chronic use, intermittent use, right? They're good for kind of like limited sort of cases there, right? Intermittent symptoms are going to be better use for antacids there. Because what was the limitation of antacids? Well, how do they work, essentially? They neutralize the acid in the stomach. How does the stomach respond to that? Make more acid, right? You have the hyperglycemia that develops there, so it tries to make more acid. So it's self-limited in efficacy, right? Good for kind of intermittent symptoms, but you're not going to use it every single day around the clock like you would something like an H2 blocker or a proton pump inhibitor. It's just not going to be that effective here, but good for intermittent side effects. But think about things like if you were giving Tums to a small kid, what could develop? It's a common side effect of calcium carbonate. Constipation, right? Finding constipation is a big issue in a lot of these kids already, and we'll talk about laxatives in just a second here. But just think about that, right? Also think about other medications. What could be binding up and causing some drug interaction? Calcium is going to bind up a ton of stuff. Throw on multivitamins or throw on any of the medications that can bind that up. I actually had a case yesterday where we had this kid who was getting ordered a bunch of home meds, and they were on, they had chronic renal failure, and so what electrolytes normally is most commonly abnormal in kids with renal failure, or anyone with renal failure? Potassium, right? Usually they have hyperkalemia. So this patient was on a drug called sodium polystyrene sulfonate, or Kxalate. I've never heard of Kxalate before. Sometimes used for hyperkalemia. It actually binds up potassium in the GI tract, and then you can basically eliminate it through the feces. So, but because it binds up potassium, what else do you think it binds up? Everything, right? So again, a ton of drug interactions from as far as binding up things. Well, this kid was like on like 5 or 6 other medications. And so the provider just ordered them all together at the same time. And so fortunately to be like, well, wait a second, well, how is this patient actually taking it at home? Fortunately, I was able to contact the nurse, and they talked to the mom. They're like, oh yeah, normally they'll take everything at 9 o'clock, and then they'll have the SPS or the Kxalate 3 hours afterwards. I said, okay, that makes more sense. So that way I can try to schedule it out like they do at home, so that way I'm avoiding those drug interactions. Because again, some of the meds the kid was on was anti-seizure meds. So again, if I just said, well, let's time everything together, and all of a sudden kids started having seizures, that's kind of on us, right? Because we didn't time things out appropriately. Okay, so these are things to think about. Are these drug interactions? Is drug interactions, drug food interactions, etc. Okay, just something to think about. Other things, sodium alginate, relatively effective. Carafate we actually use pretty frequently. This is really good, especially for protecting the esophageal mucosa. We use Carafate pretty commonly. This is also sometimes used for kids like on chemotherapy and things like that, especially getting stomatitis. From that, it's a nice kind of coating, very soothing on the mucosa there. So we use that occasionally. And again, our prokinetic agents are trying to stimulate peristalsis lung. It'll increase that lower esophageal sphincter tone to try to prevent any kind of retrograde movement of food particles and acid there. And as I mentioned, Regulatin and erythromycin are most common. Erythromycin is what I see 99 times out of 100 for most kids here. Again, metoclopramide, just remember that dopamine antagonist is going to be the main source of side effects for these kids there, especially if you're using more high doses. And again, we don't have to use it quite as frequently. Especially because, especially for cancer-related nausea and vomiting, we're using things like Zofran much more frequently nowadays. We don't have to worry about that so much, but just realize that it could be an option. And then erythromycin is a good option here because it's stimulating those motilin receptors. But again, think about drug interactions. Again, think about test questions. If I said a patient could not receive erythromycin, what's an alternative they could get? Again, think about other options. Think about things like Regulatin might be a good option there. Okay, so think about alternatives based off of what patients can or cannot receive. And then we know with our H2 blockers, really the big one we want to avoid is going to be cimetidine. That's probably safer for kids to get cimetidine. Why do you think that is? They're typically not as many drugs as you would see for an adult patient, right? So again, take a typical 50, 60-year-old, they're probably on a laundry list of medications versus a young kid, less likely to be on that. So for a CF patient who's on a ton of stuff, probably avoid cimetidine. For a kid who's on nothing else, cimetidine is just fine, right? But again, think about that. Usually Xantax, the most common one we run across as a liquid formulation, we use very frequently. Nowadays we use a lot of famotidine IV, but either of these are totally fine. And then your proton pump inhibitors. Again, these can be a little bit difficult. If you remember, I was talking about the proton pump inhibitors. How do they normally come as far as their dosage form? Remember those little beads I talked about? So the proton pump inhibitors, they are basically they get broken down in acidic environments, and so we coat them in a acid-resistant sort of protective coating. So if you ever take if you ever go get omeprazole or something over the counter, if you open up that capsule, you'll find a ton of little beads in there. And what we will find is if you were to say crush those up and just ingest it, like if you put it into a liquid, the stomach acid will neutralize it, destroy it basically, and then you have no drug being able to be absorbed, which is a problem because how do kids normally need to take drugs like young kids? take liquids, right? Because again, they usually can't take big capsules or tablets. So one of the things we'll actually have to do is, even though we know we're going to get some decreased efficacy, we'll actually have to make specially formulated compounds of our proton pump inhibitors so they can get into a liquid formulation and absorb it. And so actually how we make it is we'll mix it with sodium bicarb, and that will then break down that coating and then allow the free drug to be there, and then we'll put it in suspension. And we know some of the drugs are going to get broken up, but it's better than no drug at all for some of these kids. And so it's something to consider there. So again, most of the time you put them on H2 blocker because there's commercially available products that's easily able to get versus when you have to custom compound, right? Make sense? Just little things to think about. All right, as constipation goes, it's a very frequent complaint, especially in the ER. You have a lot of patients who are FOS, full of stool, right? And so why do you think kids get constipated? They're dehydrated. Most of the time, yeah, most kids do not get enough water. Most adults probably don't get enough water. We're all taking caffeine right now. What does caffeine do to your hydration status? It's a diuretic, right? So you're actually... It's a prokinetic too. It is a prokinetic. Well, it's not necessarily just the caffeine. I mean, if you think about it, just the smell of coffee is enough to trigger sometimes a BM and the AM, right? Put a little pep in your step, as the case may be. But have you guys ever heard of like coffee enemas? Do not recommend them. It's not something we're going to cover here, right? So some people have tried that and try lots of weird stuff. But typically you find it could either be due to dietary issues, right? The food they're ingesting, the lack of water, lack of fiber, could be related to underlying disease. So if they have like CF, potentially we mentioned that can be a big issue there. And then a lot of times they have more functional constipation, right? So again, especially from a behavioral sort of standpoint, if they get scared about using the bathroom, or if they had a painful experience or something that is really unpleasant to them, they may have a really big kind of psychological block to doing it. So that's because it can cause them to become constipated over time because they just don't want to go to the bathroom, right? And so, again, we know that there's kind of two main ways to regulate this. We have the internal sphincter, we have the external sphincter. Which one do we have control over? External, right? And so looking at that, by increasing that swelling there, or the increasing the stretch there in the towards the rectum, that's what usually stimulates that defecation. And so that's one of the ways we're going to treat that. And again, what kind of drugs are going to be used to kind of stimulate that stretch there? Yeah, so bulk forming laxatives could potentially do that. What else? Our enemas are going to be another big way to do that as well, right? Because remember, we're talking about enemas being administered rectally, so we're instilling a lot of fluid there, and it's going to cause a lot of stretch, and that usually stimulates pretty urgent defecation right there. Anyway, looking at the actual bowel movement habits, you're going to find it changes pretty greatly between kind of early stages of life moving on. So for instance, during the first week of life, maybe 4 or more stools per day. Again, the consistency is going to change pretty greatly as a kid is changing their food sources. So whether they're breastfed, formula fed, once they start transitioning over to solids, that usually going to have big changes on their bowel habits. It's going to change the consistency of it, and it can be pretty difficult. So if a kid's small infants used to having pretty liquid stools, and now they're switching over to more solids, what do you think it's going to cause? Usually leads to constipation, right? So that can be a big issue, especially if they're trying to go to sleep and their stomach hurts and they can't pass stool, and it keeps their parents up all night. Not that I know anything about that. Last night was a bad night, is all I'm saying. But you're going to find that as they get a little bit older, you're going to find it typically will kind of even out a little bit, usually 1 to 2 stools per day typically, right? As I mentioned, things that can lead to that painful defecation, things that causes voluntary withholding of stools, which again leads to that backup, leads to that abdominal discomfort, abdominal pain, usually why they end up in the ER, is due to things like either changing their routine or diet, stressful events. Toilet training can be pretty traumatic for a lot of kids, so you have to kind of gently kind of introduce that to them. Lots of things can deal with this. Oftentimes, postponing defecation due to kids being too busy. That sounds ridiculous. I thought it sounded ridiculous too until start taking my kid to the park a lot, and I'm like, hey, you need some water, and she's like, and keeps running off and go down the slide again, and I'm like, no, you need some water, you're very red, you need some water right now. Keeps running off. You need some food, I can tell you're hungry, you're becoming a pain in the butt. And then she's like, and keeps playing until she has the inevitable freak out, and then you have to like surfboard her out of the park. So kids really like to play, as it turns out, and they don't like to take care of themselves. So trying to make sure you kind of slow them down. All right, you need some food, you need some water right now. Going to the bathroom is kind of the same thing, right? I do the same thing with video games. I'm just like, I'll go later. Just kidding. That's gross. I don't know why. Anyway, so things to look at, right? So again, look at the definition of constipation for the family, right? So what do they define as? Is like they haven't had a bowel movement in a day. Probably not really true blue constipation yet, you know. So give it a few days, kind of see, you know, how things are going on. You know, have a description of the kid's bowel movements. You know, is it, you remember those? What was the Bristol stool chart that we used? You know, things like that. How do they describe it? Is it a bunch of little rabbit pellets? Is it all liquidy? You know, is color? All that kind of things can kind of help you out there. And again, looking at the psychosocial exam, history, you know, kind of seeing what's going on from that standpoint. And again, most of the constipation tends to be pretty functional here, but if you having issues you can't really figure out, you know, if that's not really the case, then you have to find out what underlying disease could be playing a role here. So it could be things like hypothyroidism, you know, cystic fibrosis, etc. But also consider things like, you know, breastfed infants. They tend to have a lot greater variability because what is influencing what they're getting to eat, what mom's eating, right? So again, her changes in dietary habits could be playing a role in the kids' dietary habits, essentially, right? So it's something to consider there. A lot of times they just need reassurance, right? They just need kind of close follow-up. Not a whole lot of therapy is needed there. However, oftentimes, especially when they're presenting to treatment, you know, they usually want you to do something for the patient, especially in the ER. This is where we can do things like disimpaction, either manual or we can use it with drug therapy. And then we're going to look at maintenance therapy as well. So what do you think are some good maintenance therapy options based off what we talked about in the GI section earlier? So one, dietary, you know, behavioral modification. As far as medications go, what do you think are good, like everyday sort of medications you can put a patient on that are okay from a constipation standpoint? Miralax is okay. So Miralax is what kind of can't even think of the word. Laxative, thank you. I said diuretic, but I was like, no, diuretic of the GI tract. Words no work good. Yeah, so again, as in laxative, it works as a osmotic agent, right? So that will help to draw water into the GI tract, help kind of stimulate that stretch, causes defecation. Good. That's a good everyday sort of medication you can use, right? What else? Emollients are fine, such as Docusate is a good one, right? Docusate or Colace is a really good one you can use potentially every day. What else? Like bulk forming agents like psyllium husk, methylcellulose, any of those like kind of non-digestible fibers are going to be good to help kind of bulk up the stool and help to make it a little bit easier to pass there, right? So the goal is to not give them stimulants, because what happens with stimulants? Not necessarily electrolyte shifts so much, but it's more of an issue. They become physically dependent on having those stimulants around, right? So again, if you don't use it, you lose it. So if you have these stimulants that are stimulating defecation, you're not kind of actively using those muscles. They tend to atrophy, right? So that can lead to things like that cathartic megacolon that can happen after a period of time. So again, try to limit how much stimulant laxatives you're going to give to them. What else would I not want to use routinely? Yeah, typically fleet enemas are a big one we don't want to use super routinely because why? What's in a fleet enema? Sodium phosphate, right? Fleet is the brand name, just like you say Band-Aid or a Q-tip or something like that, but fleet enema is sodium phosphate, right? If I give them too much phosphate, you develop hyperphosphatemia. Small kids, especially very young kids, have died from that. Just like very old patients who have poor kidney function potentially have died from that before. Because again, usually at the very early stages of life and the very old stages of life, they tend to kind of turn back into one another a little bit. So you see a lot of constipation either in, a lot of issues with electrolytes, you know, et cetera. But this is one of those things where, you know, you have to ask about what did they try already, because you can go anywhere and get a fleet enema, and if the family's coming in and say, oh, you already tried a fleet enema at home, I'm probably less likely to give them another one in the ER, because those kind of recurrent doses can lead to hyperphosphatemia, can be an issue there, right? Other things like, you know, you can use things like tap water enemas or soap suds enemas, but what's the problem with that, do you think? If I just use straight tap water, that kind of should cause hyponatremia, right? Because again, if they're absorbing all that water, all that free water potentially, that can lead to things like hyponatremia. So typically, we like to use things that are, you know, have some degree of electrolytes in it, and be very careful if you're using recurrent doses, especially more than one in a day. Be very careful with that, right? But things like, you know, bulk forming agents, you know, emollients, you know, osmotic agents like low dose Miralax, and those are totally fine for kind of standard daily therapy there. And of course, for actual fecal impaction, typically, we can either use oral, rectal, or a combination of the two. For oral routes, what could I use for disimpaction? Something like mag citrate's a really good one. We're going to talk about the green rocket. You're seeing milk of magnesia or mag citrate. If you remember, calcium carbonate slowed things down, aluminum slowed things down, but magnesium was very good at speeding things up and cause diarrhea. So mag citrate could be a good option there. Why do we call it the green rocket? Anyone know? It comes in a big green glass bottle. I call it a rocket. Because taking, you got to run to the bathroom like a rocket, right? That's how they describe it. So that's a good option there. Typically, we'll find it's a little bit slower acting. What else could I use to really kind of clean out the entire GI tract? Lactose could potentially be. We don't use it too frequently in kids, though. I see it very occasionally. Usually, we'll use it for like hyperammonemia related to like hepatotoxicity. Go lightly, right? So again, if you use high dose polyethylene glycol, so Miralax is typically you're dosing like 1 capful at a time, it's like 17 grams. Typically with something like Miralax, or I'm sorry, Go Lightly, you get the big 4-liter jug. That's like 236 grams of the stuff that you're going to be flushing through there. That's very good for evacuating the entire GI tract. Now again, we're not going to use that very frequently in the ER, but I have a lot of kids get admitted to the hospital for a GI clean out. Again, whether it's related to functional issues, nutritional issues, etc., but they get admitted, they have to have an NG tube being placed. Because again, is it easy for a little kid to drink warm Gatorade? It doesn't taste very good. They're not going to keep up with that amount. And again, they're getting like 200, 300, 400 mLs an hour, which could be a lot of volume for them. So they have an NG tube placed, have to run it through that, clean them out. They're in a hospital stay. It's expensive. So again, if you can avoid that, it's always going to be beneficial. But it's useful if the other routes are not really working for them. But again, rectal is typically a little bit faster, a little bit more invasive. So again, if you think about like the patient coming in, if it's a 3-year-old, you think you're going to get too shy about getting an enema? Probably not. Versus say like a 16-year-old, they're probably going to be like, you want to do what? No, thank you. Right? And I had some of these docs, like old school pediatricians, there's like 16-year-old females are coming in. They're like, we're going to give them an enema. I was like, that's just mean, man. Like, you want to try something else first? And they're like, no, we're going to take this problem, get taken care of right now. Sure enough, it worked, but you have to think about what's going to be, appreciable by the patient, essentially. Right? What are they going to be compliant with? So again, other things, mineral oil has potentially been used before. This can actually lead to some fat absorption of fat-soluble vitamins in the past. There've been some issues there, but again, usually the most common one's going to be the polyethylene glycol or Miralax solutions there. And these also could be used, Senna, bisacodyl, lactulose, and these are good for oral options for treatment of constipation. As I mentioned with the rectal enemas, typically things like sodium phosphate is going to be the most common one because it's a Fleet's enema. That's how it normally comes. But we'll also use things like mineral oil, bisacodyl enemas, or suppositories. A lot of different options here. For the really little kids, usually in the first year of life or so, when they're still an infant, this is where we like to use glycerin suppositories. They tend to be the most sensitive to things like that, hyperphosphatemia and whatnot, so glycerin works very well for them. You just kind of insert rectally, hold their cheek shut, allow it to melt, and that will usually cause enough of a sensation they need to defecate pretty quick there. And again, we don't like to use soap suds enemas or tap water because they usually leads to too big of electrolyte shifts there. And again, just make sure they're getting a good, well-balanced diet, lots of fruits and vegetables and all that good stuff, plenty of water. Make sure you get lots of water in their diet there. And then sometimes by using non-absorbable carbohydrates, this can also stimulate defecation. So usually like prune, pear, or apple juice can all be fine from that standpoint. Okay. And then, obviously from a behavioral standpoint, just regular toileting, make sure you're not trying to make, potty training is a super intense kind of thing for them. Let them kind of work at their own pace, essentially, right? And then as far as like maintenance goes, right, it's not for acute sort of defecation there, things like, daily treatment mineral oil, not used quite so frequently anymore. Probably Miralax is not the most common thing because Miralax is now available over the counter, so it's much more readily available to people, so they're using that a lot more commonly. But again, try to use things like, Senna, bisacodyl very intermittently. Try to hold off on the stimulants as long as you can. Only use them every once in a while. Okay. And as I mentioned, for infants here, things like juice intake can be useful. Typically, what do your pediatricians tell you about juice intake for little kids? Not typically recommended, right? They tell you no fruit juices because it doesn't really have a whole lot of nutritional content to it. It's just a lot of sugar. However, in this case here, by using small amounts, things like prune juice and things like that can be useful because those sugars don't get absorbed very well and they just kind of will stimulate that osmotic effect and cause defecation. So again, all things in moderation. Again, Stimulax is definitely not recommended for infants. Glycerin usually works pretty well, and you'll find that used most commonly for infants. Again, infants just refers to what stage of life? First year, yeah. Good. Okay, so any questions? It's pretty good. You got 10 extra minutes for Taco Tuesday, the Fat Taco Tuesday. Make the fattest tacos you can. Oh, is there any questions? Check the board.